I hope that in the next few minutes I can share with you some general concepts regarding strabismus in adulthood. I really I'm not here to talk about millimeters of surgery. I feel that all of us who take care of these patients have our methods of aligning the eyeballs. And as we all know, that strabismus evaluation and treatment are much more complicated than just repositioning the eyes of these patients. So I want to share with you some general concepts that have been my experience taking care of these patients separately. I have a special adult eye movement disorder clinic where the education and the patient care is revolved only around adults with strabismus and other eye movement disorders. So I'll share some of my experience as well as some of the experience in the literature regarding how this has changed. And I think there's one caveat. What I'm presenting to you is within the context of the culture in North America. And I know that it's different in India, and I'm always interested to hear what the differences are and how they may be different from our experience. So I want to begin with a case report. A typical case is a 54-year-old male who had diplopia and ghost images, and he was having trouble with down gaze. He has a very stressful occupation, and it was nearing the end of his current job, and he was feeling a lot of stress over the last few years. He was complaining of second images and ghost images and dreams, that he thought these were dreams that predicted his future, actually ominous dreams about his future. He did have facial trauma when he was young. He worked outside, did a lot of woodwork. There was a family history of strabismus in his mother, who passed away when he was young, and there was a history of depression in him and in the family. This is his motility examination. This is the sheet that I use to ask our fellows and residents to fill out. This is the patient looking at us, and as you can see here, the patient has an incomitant left hypertropia, which is worse on left head tilt, and has some fusional ability which is disrupted as a result of the decompensating incomitance. And here's a photograph of the gentleman's face. I don't know if any of you recognize this man. He was the 16th President of the United States, and here he is in right gaze showing his left hypertropia, and he did not like to look to the right, so even when he was supposed to during a photograph down here, he kept his gaze straight ahead. And so it turns out that Abraham Lincoln did have a left underaction of the superior oblique. I don't call it a superior rectus paresis because we don't know that's what it is. All of the work on the orbital and extraocular muscles to this date show that it may not be a nerve problem, it may be actually a muscle problem or a tendon problem, more accurately, maybe the result of a redundant tendon, and actually a minor form of CCDS. So here's some of the misconceptions. When I started, and I still hear this from patients, you can't treat strabismus after childhood. It's impossible. You're going to get double. If I do strabismus surgery on you as an adult, you're going to get double, and it's only cosmetic, whatever that means. I don't know what cosmetic means anymore because reconstruction of the face is extremely important for psychosocial interactions, job interviews, school interviews, relationship building, self-confidence, and self-esteem. And there's a growing literature on the psychosocial importance of facial reconstruction, particularly the eyes. It's not covered by insurance in our country. It is covered by insurance. As a matter of fact, strabismus surgery, adult strabismus surgery, is a very lucrative practice in the United States. It's risky for whatever reason in adults, more risky than in children. And it's painful. I think that the three things that I've learned in 30 years of medicine is that one is I'm a suggestion box. All I do is suggest to people what to do, either verbally or on a piece of paper. The second is I create pain because everyone I operate on hurts after I operate on them. And if it wasn't up to nature to heal them, I wouldn't be a surgeon. And the third and most important thing is I provide hope to the families, and that's more than the other two combined. There's a long post-surgery limitation. You won't be able to work for 5 years after your surgery, so you need workers' compensation, and that's not true either. So I have to break those misconceptions with the referring doctors, particularly the adult ophthalmologists as well as the optometrists in our country, because they're still taught that. So this is a joint statement that was put together. These are committee-generated by specially appointed committees, both as part of the American Academy of Ophthalmology and the American Association of Pediatric Ophthalmology and Strabismus. And these statements are put forth to try and reinforce the need and reimbursement. These are done really for commercial and insurance reasons, but in the end it turns out that they also allow us to see these patients and to get the message out to the general ophthalmic community. These conditions, as I mentioned, result in many psychosocial conditions, and successful strabismus surgery is an important part of the care of a modern patient, especially as an adult. So the pathophysiology of this is broad. It's actually, if I explain to the fellows and the residents who work with me, if they understand adult strabismus, they will understand child strabismus. It will appear simple to them. All children with strabismus will appear much simpler to diagnose and understand if they understand the consequences of living a long life with childhood strabismus, even after having multiple treatments. So the way that, and I'll talk a little bit about classification and nomenclature and eponyms, because I think these can be very confusing. As the world is becoming smaller and we're starting to communicate more about what we do and what we understand and how we investigate these patients, it's important that we're talking about the same disease. So I undertook a little bit of a experiment. And so what I did was I presented a patient whose eyes crossed, who was 7 years old, and then we put plus lenses on him and the eyes straight. And I took the same patient, presented them just like that to audiences all around the world, and no two audiences gave me the same diagnosis. Same patient, same problem, same treatment everywhere, but no one called it the same name. And so it was very confusing to me. So this was in the mid or early 90s, and we put together an NEI, a National Eye Institute-sponsored workshop on the classification of eye movement abnormalities and strabismus, which we use nationally when we begin our clinical trials, and I'll share that with you. But in general, with adults, there's an additional classification that needs. I think that the first thing we need to try and understand is whether these adults have the onset of their strabismus before or after visual maturation, whenever that is. It depends on how we classify it, when the neurophysiology is more hardwired than not. It's never completely hardwired, or people wouldn't learn new languages when they're adults or learn new sports or new skills. So it's important to understand when it's ABM or BVM, and one of the biggest clues to that is whether the sensory system. The sensory system will give you a clue to whether the onset of their strabismus is before or after. If they have constant diplopia and only an ability to fuse when the eyes are properly aligned, the chances are that this occurs. Yes. Did you want to ask a question? Okay. So the classification really is when is the onset, how long has it been going on, and whether the disease is occurring above or below the level of the oculomotor nuclei. This is the first step in classification. If the deviation is comitant, then the disease occurs above the level of the oculomotor nuclei. If the disease is incomitant, it's at the level of the oculomotor nuclei or below. Which direction do the eyes go, of course, is important. Whether there's other eye disease, other brain disease, systemic diseases, and these are important parts of the history which may or may not be obtained from a child whose eyes straighten with plus lenses. And we have to get these on all of our adult patients. We can't assume that just because an adult is coming in with cross eyes, it's a childhood form of strabismus. As a matter of fact, 70 or 80-year-olds now with decompensating esotropia due to some orbital diseases are being underdiagnosed. So I'm going to share with you the CMAS. This is the classification of eye movement abnormalities and strabismus that was done as a result of work at the Eye Institute. This is available online. You can go to the NEI website and get the document, which is 85 pages. And this is an example of one of the diagnoses, or infantile esotropia syndrome, or old congenital esotropia, and I'll talk about this later as well. Congenital esotropia doesn't exist. Babies are not born with large angle ETs. And this has been done, the result of numerous studies looking at newborns in normal nurseries throughout the country, throughout our country, thousands of babies. This is an acquired disorder of the oculomotor system. Just because it's acquired at 6 to 12 to 18 weeks of age doesn't mean it's any less acquired than if it developed at 40 years of age. It's still acquired. The child was not born with it. The eyes were not crossed in the womb, so it's not congenital. And this is important because the acquired developing neurological system is much different than the developing system in the womb. And so the main criteria are seen in this box. This is a box classification which allows us to enliven the classification system. And these are the characteristics that were agreed upon by this group. Remember, this classification was done to use as a starting point for either natural history or interventional clinical trials. The treatment indications in adults are the ones that you see here. I won't read them to you. These are all the things that patients complain about either directly or indirectly. As a result of an anomalous head posture, their single field of binocular vision may be restricted or limited in some direction in space. They're intolerant of previous medical prescription, medical treatment, including glasses and or medications, prisms, or orthoptic therapy. And these are a large number of indications for treatment in the adult population. The treatment modalities include medical, optical, and surgical treatments. Glasses and contacts are very important. As you can see down here, you may know this person, which may be a future president with an eye motility problem. This is Hillary Clinton, and she's wearing face-out Fresnel prisms in the left eye because she had a transient sixth nerve due post-viral. This is a synoptophore for orthoptic therapy, so prisms, orthoptics, patching. Botox is really kind of in between. Is it medical? Is it surgical? I don't know. If you stick a needle in someone, is that surgery or medicine? The law has to help us decide that. I'm not sure what that is, but I put it in medical treatments and also surgical treatment. And those are the things that we have available. This is a list I'm happy to share with you of probably some of the relevant literature on adult strabismus, but I'm going to talk about an adult strabismus review that was guided by George Beauchamp recently, and this was a retrospective study of strabismus surgery in '99 that was from 11 centers in the United States, 6 centers, 11 specialists. And they sent in data on standardized worksheets on their patients who were done pre- and post-operatively. So this is a study of surgery in adult patients only who were done at these centers. And it was compared to 2 other. One was retrospective by Dr. Scott, and our study, which was prospective, which was 300 patients over a 10-year period when I was at Penn. So there's 3 large studies with this. But this particular study showed 299 patients. They also used the classification of AVM and BVM. About half were female. A mean age at the time of surgery was 50 years old. And interestingly, this group of patients is usually referred, at least in our culture, by eye care professionals, as opposed to pediatric ophthalmology, where our strabismus patients are referred by pediatricians. And the results were 62. 2/3 of them were adult onset strabismus, or after visual maturation, and 1/3 were before visual maturation. In my study, it was reversed. So if they had a family history, they were more likely to have their onset before. If they had a developmental problem, they were equal AVM and BVMs. If they had strabismus as a problem due to some other disease, they usually were adult onset. Paralytic, of course, was adult onset, mostly, not childhood, and previous muscle surgery was before visual maturation. Prism lenses were mostly used in the AVM group. Exotropia was seen more in the BVM group, vertical deviations alone in the AVM group, and primary position deviations were equal in both groups. And this is a summary of the results of all of these patients, and you can see here that diplopia was the most common result, and other complaints included all of these things that you see here subjectively. And these put together, no patient had one complaint. Most of the, if not all of the patients who came in had multiple complaints about their eye movement systems. Alignment success was about 72%. And this is with surgery, and I think that this is a realistic number. Most of us, if we look at our patients over a long period of time, about 70% of our patients are aligned with one operation. This is with one operation. And they had strict criteria of 8 and 2. Usually we're a little more liberal with our diagnostic, with our success results of within under 10 and under 2. And the AVM group had a higher success, probably because their fusional potential was better. And they were equal if they did. It's interesting, if you saw a person with childhood strabismus and they never had surgery before, and you operate them for the first time as an adult, the success rate was equal, higher than if they had previous operations. And this is a slide showing a comparison of the 3 studies. This study by Beauchamp, Bill Scott's study from Iowa, and our study at Penn, showing the differences between the groups. And part of that is explained by the criteria. Our criteria was a little bit larger than the 8 and 2 and 8 and 15 seen in the other 2 studies. So what can we say is that this is a huge problem. The incidence of childhood strabismus is somewhere around 4%, and my feeling is that we don't cure childhood strabismus, we just treat it. I don't have many patients that I've treated over 30 years that are like me after I treat them, which I don't have strabismus, and it's cured. So many patients we make better, most patients, we don't make it go away. So if we take that 4% and we add adult acquired onset strabismus in adulthood, we have a higher than 4%, probably somewhere 6-8% incidence of strabismus in the adult population, which makes the need for evaluating and treating these patients even higher. So I hope in this short period of time you will be able to enhance your practice and enhance the lives of these patients by including them in your treatment plan. I guarantee this will be very rewarding and very challenging. Thanks for your time.